We can start the session, and today I have kept few questions from previous years of NEET-PG exam. Now before I take the session proper, let me tell you a few things. What I have observed, that the questions are not that easy like what we used to see in FMG exam. So questions are not that easy, and moreover, because in FMG most of the time the questions are from traumatic orthopedics, but here the questions are mainly from non-traumatic orthopedics, right? So that was one difference which I could easily spot out. So and definitely the level of the question was little difficult too. So we can start the session. The very first question is about a 7-year-old boy who is presenting with painless limb for around 4 months, and then there was restricted abduction and internal rotation, and then X-ray pelvis APV was given. Now what was the most likely diagnosis? So let us write the keywords first, and I am very sure once we are done with this you will never do any mistake in these kind of questions. So here the age is 7 years, the gender is a male, then presenting complaint is painless limb, right? So there is no pain, that's very important. Then the movements at hip joints are restricted, especially the abduction and internal rotation. Clear? So this is what has been given in the case history. Now we need to study the X-ray also. So this is the normal side, okay, and this is the affected side. Okay, so now what you can see here, this is the femoral head epiphysis on the normal side, and look at the epiphysis on the affected side. So when you compare the two epiphyses, this is obviously the normal side, something like this, but look at the affected side, it is in pieces. So what we call it? We call it fragmentation. Clear? So one of the keyword is fragmentation. You can see that some pieces are like this. So this is the fragmentation, and obviously where we are discussing these changes, these are in the femoral capital epiphysis. Clear? Age is 7 years, so this is epiphysis. Capital means head, so epiphysis of femoral head. So one thing which we can see, that there is fragmentation. Now second, look at the space of hip joint. So this is on the normal side, but look here, this is on the affected side. So what we can write? Increased joint space, right? Increased joint space. And third, since the head of femur is flattened, the epiphysis of the femoral head is flattened, so we will write it coxa plana. Okay, so what word we will use here? That is coxa plana. Okay, so this is actually flattening of femoral head epiphysis. So the moment you see these three changes in any child less than 10 years of age presenting with a painless limb. Now painless is very important here, again and again, painless limb, right? So painless limb, less than 10 years of age, restriction of activities, and X-ray showing increased joint space, fragmentation of femoral head epiphysis, and coxa plana. Straight away the diagnosis has to be Perthes disease. Okay, so the diagnosis has to be Perthes disease or Legg-Calvé-Perthes disease. Clear? So this Perthes disease is very favorite for exam setters, and one should not confuse with slipped capital femoral epiphysis or other entities. So this is classical presentation, the classical X-ray features, and obviously the pathology is like frequent episodes of frequent avascular episodes. So that was causes fragmentation or deformation of the femoral head epiphysis, right? So this is classical presentation for Perthes disease. Please remember. Then next question. Now this is very favorite for exam setters, like can be every time they will use this topic and they will give you some or other questions. So now here a male patient presents with chronic back pain, okay, and anterior uveitis for several months, and there is tenderness in the sacroiliac joint. X-rays are normal. Now what you will do here? So again we can write the keywords first. So the patient is a male having low back pain, okay, chronic low back pain, and then what else is given? Anterior uveitis. Now this is very classical. The moment you see a patient, a male patient with low back pain and anterior uveitis, I think this is classical to make a diagnosis. But we will write another feature also, that is tenderness in sacroiliac joint. Clear? So out of all these features, anterior uveitis, the moment in orthopedics, there is only one condition for which you need to remember anterior uveitis, and that is ankylosing spondylitis. Okay, so the moment you find this word anterior uveitis, low back pain, straight away go to ankylosing spondylitis. Right now, the basic pathology in ankylosing spondylitis that there is formation of syndesmophytes. Okay, so there is formation of syndesmophytes between the two vertebral bodies, and therefore there is restriction of the joint, the spine movements. And if you take X-ray, what you have learned, bamboo spine, right? But here this is showing everything normal, right? So this bamboo spine comes very late. So now what we need to do, we need to go for, especially this is the earliest joint to be involved. SI joint is the earliest joint to be involved, and usually we can see the changes in X-ray. But if X-ray changes hadn't been developed yet, then we should go for MRI of sacroiliac joint. Clear? So we should go for MRI of sacroiliac joint. This will show you marrow edema or maybe some changes of osteitis. Clear? So if X-ray is normal, go for MRI. So X-ray is normal, so go for MRI. And I think everyone must have understood what is this condition. This is ankylosing spondylitis, and earliest joint to be involved is sacroiliac joint, and that is sacroiliitis. Clear? So this very favorite, ankylosing spondylitis. Please read this topic in detail. Then moving forward to next question. Old lady presented with again low back pain, right? And the pain worsens on prolonged standing and walking and is relieved by rest. There is no history of any trauma or any other symptoms, and then the lateral X-ray of the LSS spine has been given to you. Now what we can see here, see this is first sacrum, this is L5, this is L4, this is L3, this is L2. Okay, so this is the numbering. Now normally what should happen? All should remain in a straight line like this, but what we are noticing here, L5 is here, L4 is here. So now what has happened? So if I draw, suppose if I draw something like this, so this is for the upper vertebrae and this is for the lower part. So now what we can appreciate, that there is movement of the L4, that is anterior movement of the L4 over L5, right? So the L4 has moved in front or anteriorly with respect to L5, and this condition is known as spondylolisthesis, right? So what is this known as? Spondylolisthesis. Clear? There is anterior movement or anterior translation of a vertebra over lower vertebra. Okay. So in this case, if someone asks you what is the level of spondylolisthesis, this is L4, L5. Clear? So the L4 has gone anterior with respect to L5 vertebra. So this is spondylolisthesis. Now there is one more word, retrolisthesis. Now don't mix up. Now retro means past or back. So here what happens, instead of anterior there is posterior translation of a vertebra over lower vertebra. Okay. So if the L4 is going anteriorly over L5, that is spondylolisthesis. But suppose if the L4 is going backward or posteriorly with respect to L5, that will be known as retrolisthesis. Okay. So retro means past or back or historical, like in other words. But here this is especially related to backward movement of a vertebra with respect to the lower vertebra. So there are two terms, spondylolisthesis and retrolisthesis. Please don't mix up. It is very easy to diagnose. If it's going anteriorly, spondylolisthesis. If it is going posteriorly, it is retrolisthesis, right? So this is how you should solve this kind of question. So this is about spondylolisthesis. Then moving forward to next question. Now here a old male has generalized body ache, okay, and there is progressive enlargement of his head, right? So there is progressive enlargement of his head, and therefore what is happening, he has to take a larger hat again and again. So he is requiring a larger head size over the past few years. Then the affected bones are warm to touch, and then the radiographs shows mixed lytic and sclerotic lesions, and there is cortical thickening. Now what is the diagnosis here? Now let us write the keywords first. So elderly male, obviously. Okay, so elderly male, then there is generalized body ache, then progressive enlargement of head, and just because of this, head size is increasing, right? Every time he has to take a bigger size hat. And then what is happening? Warm bones, right? So bones are appearing warmer, and then on X-ray showing mixed lesions. Mixed in the sense lytic as well as sclerotic. Now this all, and obviously there is cortical thickening as well. So there is cortical thickening. This is also a very important point. Now this is one condition which is known as osteitis deformans, or the another term is Paget's disease, right? So this is the classical presentation for Paget's disease or osteitis deformans. Now here what keywords you need to remember? One is obviously elderly male. Secondly, there is enlargement of head. Then third, the bones are warmer. Now this is because of increased vascularity. Okay. And what else we see? On X-ray, there is cortical thickening with lytic. Lytic means damage to the bone, right? So bone, there is damage to the bone area, and sclerotic means there is whiteness which will be seen on the X-ray. So this is very classical for osteitis deformans or Page's disease. And here sometimes we have some more extra keywords, like there might be deafness. Clear? So if there is narrowing of the internal acoustic meatus, patient might have deafness. Then if we go for lab test will show everything okay except increased alkaline phosphatase. Clear? So these are some more keywords which we often find in the exam question. And then apart from this, on X-ray we can see some cotton wool spots, right? So sometimes there is mention of cotton wool spots. Treatment is obviously by bisphosphonates. So this is all. And yes, what is the risk of this condition? It can later turn into osteosarcoma. Clear? So it can turn into malignancy, that is osteosarcoma. So it is a pre-malignant condition. So this is how we can summarize Paget's disease or osteitis deformans. And the bone architecture changes because there is an imbalance between the osteoblastic and the osteoclastic activity, right? So this is how you should remember this condition, very important from exam point of view, Paget's disease or osteitis deformans. The next question, now this is a very favorite topic, like 3-year-old child which is brought with pain and swelling of the leg after a tibial fall while playing, and there is a fracture of the tibia. Now the injury is very minor, trivial fall, and there is a fracture of tibia, but what is classically given to us here is widening and splaying of metaphysis. The moment you have this particular word, I think there should be no doubt whatsoever. So again, we can write the keywords first. So one is like 3-year-old child, then there is a trivial fall, and after this there is fracture of tibia, right? But what is importantly given here, there is if you look at the metaphysis, it is showing two changes. One is widening, but most importantly this is splaying. Okay, so the moment you find the word splaying of metaphysis, there is only one entity which should come to your mind. So splaying of metaphysis, the answer has to be rickets. Clear? The answer has to be rickets. Now here, apart from this, there are few more keywords which you should remember because they are oftenly included in the exam question. Now here what we need to do, especially what we do sometimes classically, you must be given X-ray of the wrist, and here you have to notice two things, right? So look at the physis or growth plate, right? So this is growth plate. And the second changes, you have to look at the metaphysis, right? So you have to look at physis, you have to look at metaphysis. Now what will happen in physis? There will be broadening or increase in width, right? So there will be broader physis. And what you need to remember in metaphysis, there will be cupping, splaying and fraying of metaphysis. So these are the classical words which you need to remember: broadening of physis and cupping, splaying or fraying of metaphysis. The moment you find these words in your exam question, please mark rickets. Okay, so that's very classical. So suppose if this is epiphysis, this is somewhat like the normal metaphysis. But what will happen in rickets? suppose if this is the epiphysis, the metaphysis will be something like this. Okay. So what is happening? Number one, the gap between the epiphysis and the metaphysis. Now this is the growth plate. So what is happening here? There is broadening of the growth plate, number one. And number two, look at the metaphysis. This is the normal surface, but what is happening here? There is widening, flattening, and the fraying, like sometimes the smoothness is gone, and this looks like paintbrush. Clear? So this is paintbrush appearance. So the classical hints for a case of rickets on X-ray: number one, increase in the width of growth plate, and number two, the metaphyseal changes. So as given in this question, the moment you find the word splaying, there should be no confusion in your mind. The answer has to be rickets. Okay, so this is classical for rickets. So many times you may have some useless hints in the questions. No need to waste your time on that. Choose the one which is very exclusive for a particular condition and go ahead like that, right? So you have to save your time as well. Then next question is about a player who is having eversion injury to the right ankle during a match, and then after that he was having pain swelling over the medial aspect of the ankle, and then there is tenderness below the medial malleolus while the lateral ligaments are okay. Now which ligament you think is injured here? Now here suppose now let us take the keywords first. Now here look at the type of injury. This is eversion injury. I think most of you must be knowing what is eversion. Eversion is when the sole faces laterally. Okay, so eversion means the sole is facing laterally. Okay, so sole is facing laterally. Now as the sole faces laterally, what happens? There is stress over the ligaments on medial side of ankle joint, right? So it means there is a stress over the ligaments on the medial side, and if there is too much of eversion injury, these ligaments can get torn. So answer here is ligament on the medial side. And yes, see here the lateral ligaments are okay. So as given here, the lateral ligaments are okay, they are intact, right? Now the main thing is like which ligament on the medial side. So here the ligament on the medial side is similar to a name of a muscle, and this ligament is deltoid ligament. Clear? So this is deltoid ligament, because I think most of the students, they remember deltoid muscle, but this is deltoid ligament on the medial aspect of the ankle joint, and especially injured if there is a eversion injury. If there is sudden forceful eversion when the sole faces laterally, then the medial ligament complex is stressed out and there are chances of injury to that. So this is ligament, deltoid ligament. Now what are the ligament? This is actually a complex. Now what are the ligaments which are included in this? So here we have actually 4 ligaments which are there on the medial side. One is of course connecting the and all the 4 are actually connecting the tibia to the surrounding bones. So the one which is going towards the so suppose this is tibia. So firstly you should take the nomenclature first. This is tibia, this is navicular, this is calcaneum, right? And then this one is talus. So you can see one ligament is going from the tibia to the talus. So this is anterior tibiotalar. Similarly, one ligament is also going from tibia to talus, but on the posterior aspect, so that is posterior tibiotalar. Then one ligament is connecting the tibia to the navicular, so that is tibionavicular. Similarly, if you can mark one ligament which is connecting the tibia to the calcaneum, it becomes tibiocalcaneum, right? So very easy to remember. Now this all complex on the medial side of the ankle joint forms the deltoid ligament. Sometimes there is one more mention of tibio spring ligament, because somewhere here we have the spring ligament, so that connects the tibia to a spring ligament. So anyway, but this is very important for deltoid ligament, and please remember it is injured in eversion injury to the ankle joint, although it is not very commonly injured in clinical practice, not commonly injured, because the usual injury which we see in clinical practice is inversion injury, so the lateral ligament complex is injured, right? So but this is related to the question. So eversion injury, go for deltoid ligament tear. Then moving forward, a young male going for intramedullary nailing for the mid-shaft fracture of the tibia after road traffic accident, and then 6 hours after the surgery he develops disproportionate pain in the operated leg, and that is not relieved by analgesics. On examination, the leg is tense and swollen, and there is pain on passive stretching of the toes, and this is associated with reduced sensation over the dorsum of the foot, and the dorsalis pedis is palpable. Now what we need to do in such a case? So here again let us take the keywords, and I think most of you can get the answer here. Very characteristic presentation. So is a known case of fracture mid shaft tibia, right? And this is managed by intramedullary nailing. Now what has happened, there is disproportionate pain, means the patient will shout, and we are unable to understand why he is shouting so much. Already the surgery has been done, and post operative, yes, there will be some pain, but there is no point in shouting for that pain. So disproportionate pain. Then second is not relieved by analgesic. You are giving painkillers, but still hardly 30 minutes, 1 hour, and then again the patient will start shouting. So not relieved by analgesic. Then there is pain, swelling over the affected limb, but most characteristically there is pain on passive stretching of the toes. So the moment you dorsiflex the toes, patient will have severe pain. And just to confuse you, dorsalis pedis is palpable, the pulsation is present, right? So dorsalis pedis pulsation is present. Now here this is the main clinical test actually we do to rule out compartment syndrome. Clear? So this is a classical case of compartment syndrome, and also known as Volkmann ischemia, right? So this is also known as Volkmann ischemia. So this is a classical presentation of compartment syndrome, and here now what we need to do the moment we think that the patient is going into compartment syndrome. So the very first thing, we have to remove the pressure, and that can only be done if you cut the deep fascia. So the surgery is known as fasciotomy. So for compartment syndrome, urgent step is fasciotomy. Give a incision in the deep fascia from leg till the ankle, and give some space for the muscles to breathe. So this is compartment syndrome, very commonly seen in fractures around the elbow, especially supracondylar, and fractures of the tibia, and sometimes in the fracture both bone forearm as well. So please remember this compartment syndrome. It's very favorite for exam setters. classical presentation of compartment syndrome. There is disproportionate pain which is not relieved by analgesic, and pain on passive stretching of toes. That's the classical test which we do in clinical practice. The next question, 4-year-old, right? So there is a fracture shaft of femur after road traffic accident, and then operation was done, but 48 hours later he develops acute onset breathlessness, there is confusion, and there are multiple petechial rashes over the upper chest and axilla. Oxygen saturation is dropping down. Now what is the diagnosis? Again, I think this question everybody must be knowing, because this is the one which is repeated over the years, almost in every exam, and even in the recently concluded FMG this question was there. Maybe some keywords are like plus minus, but characteristically few clues are always there to reach up to the diagnosis here. So this is a case of fracture shaft femur. Then duration is very important, more than 48 hours. After this, what is happening? There is petechial rashes, and this can be noted in chest, axilla, sometimes in conjunctiva also. Okay, so conjunctiva or neck. Then another is some neurological presentation in the form of confusion, right? So patient is confused here, and there is respiratory presentation in the form of breathlessness. Clear? So the moment you find this PNR, okay, so the moment you find this PNR, make a diagnosis of, I think everyone can answer this, yes, this is fat embolism. Clear? So especially after around 48 hours to 72 hours of trauma, it can be fracture shaft femur or polytrauma case, and PNR, go for fat embolism. Very characteristic presentation and very important from exam point of view. So you cannot afford to do any sort of mistake in this kind of question. Now, elderly male presented with acute onset pain and swelling of the right knee. Then there are degenerative changes with chondrocalcinosis, and then synovial fluid aspiration source, rhomboid shaped crystals with positive birefringence under polarized light microscopy. What is the diagnosis here? So again, we can write the keywords first. Then the patient is an elderly patient. There is involvement of the knee joint. Okay. There is mention of chondrocalcinosis. Then there is synovial fluid examination. Now what is this showing? This is showing rhomboid shaped crystals. Okay, so this is the shape, rhomboid shaped, and they are showing positive birefringence. So I think this is very classical for very good, Dhanush, very good, Bache, you are absolutely right. So now here, see the classical differences, classical points which you should know. Knee joint involvement. Number 2, chondrocalcinosis. Now chondro is what? Chondro means cartilage. So there is calcification in the hyaline cartilage or fibrocartilage. So that is known as chondrocalcinosis. And then third, rhomboid shaped crystals. Fourth, positive birefringence. And yes, this is very classical for pseudo gout. Okay. So this is pseudo gout, which is also known as Very good, Dhanush, very good. Yes, very good, absolutely right. So this is pseudo gout, which is because of deposition of calcium pyrophosphate. Clear? So this is calcium pyrophosphate, and there is deposition of calcium pyrophosphate, so it is also known as CPPD, calcium pyrophosphate deposition. Clear? So here you need to remember these common facts, and yes, it is commonly seen in hemochromatosis. Very good. So this is classical presentation of pseudo gout. Now why I am stressing on this fact, pseudo gout, because there is one more condition which many of you must be knowing very nicely, that is gout. Now in gout what happens, there is accumulation of monosodium urate, right? In pseudo gout there is calcium pyrophosphate. So this is one difference, okay? So this is one difference in terms of what is being deposited. Very good, Dhanush. Then second is, gout is commonly seen in first metatarsophalangeal joint, or you can say around great toe area. But see, in pseudo gout it is affecting knee joint, okay? So the joints are also different. Toe 5, very good, very good. Then third is the shape. In gout it is needle shaped crystals, but here it is rhomboid shaped crystals, okay? So the crystals shape is also different. And fourth, it is showing negative birefringence, but here it is showing positive birefringence. So these are the four differences. Yes, absolutely right, Dhanush. In between it may be normal. Yes, very good. So these are the four differences which you should know between gout and pseudo gout, and most of the times it is pretty easy to mark the answer, right? So it's not that different. Just look at the joint which is commonly involved, then the type, the shape of the crystals, the type of birefringence, and obviously the substance which is deposited. So gout and pseudo gout, but yes, this time it was about pseudo gout. So this is enough for this session. Very shortly I'll come up with another subject. Till then, keep on studying. God bless. Bye bye.